Welcome to the Diabetic Mogul podcast. So, greetings, friends, family, patient advocates, diabetes online community, caregivers, and to you all, my loyal and special fans, for listening. So, my name is Tino Tenda Zikiti, and I am humbled to be hosting this podcast in the best way I know how. So this podcast will focus on the sick day management in children and adolescents with diabetes. It is my hope that you will find this episode educational, encouraging, exquisite, and expedient, and help you to meet your glycemic goals. So I am internally grateful to be able to share with you the great insights from the eSpad platform by the virtue of me being a member in the most authentic sound of my voice. So to start with, I will share briefly the consensus statement from the eSpad. So they say, an episode of DKA, diabetic ketoacidosis, in a child with established diabetes could be a signal that diabetes education, along with assessment of family dynamics, needs thorough review. It may be useful to explain to family members of low socioeconomic levels and those paying out of pocket for insulin and supplies, who may restrict dosing as a means to save resources, that even a single hospital admission is more expensive than several weeks or months of home blood glucose monitoring with insulin administration, and further that any episode of DKA could be life-threatening. Now moving on to the effects of illness on diabetes. Routine childhood illness can make diabetes management more challenging and increase the risk for DKA or hyperglycemia with gastroenteritis. A study of adult patients with type 1 diabetes reported a higher risk of urinary tract, bacterial skin, or mucous membrane infections. In many parts of the world, pediatric and adolescent diabetes care is woefully inadequate because of a general lack of resources, lack of healthcare systems, lack of expert diabetes care, as well as enormous cost of diabetes care. These factors may contribute to chronic under-insulinization or marked glycemic variability in youth, especially when insulin is too expensive, which I believe it is already, unavailable, or when there is profound fear of hypoglycemia with inability to monitor glucose levels inadequately due to the cost. Now we move on. In developing countries, occurrence of DKA remains a problem. Therefore, one must have a high index of suspicion, especially among youth with poor metabolic control. That risk for DKA is high and prevention is key, with appropriate monitoring, insulin administration, and management of intercurrent illnesses. Illness often increases ketone body production due to the inadequate insulin levels and the counter-regulatory hormone responses. In contrast, illness associated with vomiting, diarrhea, for example, viral gastroenteritis, may lower glucose levels with the increased possibility of hypoglycemia rather than hyperglycemia. Decreased food intake, poor absorption, delayed gastric emptying, and or overt diarrhea with more rapid transit time during gastroenteritis may contribute to hypoglycemia risk. Moving on to the sick day preparation. These are the things that we ought to do as people living with diabetes or as caregivers to people living with diabetes. Sick day preparation. All families should receive education on sick day management. At diagnosis, families can be overwhelmed with new information, and it is common for them not to retain information about sick day management post-diagnosis. Households should maintain readily available supplies and information for sick day management, including 1. Written information on management and important contact numbers or address of the healthcare team. Consider use of mobile apps for sick day management that are available on smartphones and can be used by patients or families. However, these apps should not replace communication with the healthcare team. 3. Sick day foods and hydration supplies such as chicken soup, electrolyte drinks, etc. Sufficient glucose and ketone monitoring supplies additional insulin, and an emergency glucagon kit is essential. Moving on to more frequent monitoring. There should be more frequent monitoring. How? Frequent blood glucose monitoring facilitates optimal management during illness with adult supervision, especially in adolescents. Blood glucose should be monitored at least 3 to 4 hours, including through the night and often every 1 to 2 hours. Distinguishing illnesses associated with hyperglycemia from those associated with hypoglycemia is facilitated by blood glucose monitoring. Ketones. Now on ketones, what should you do? Ketones are produced by the liver from free fatty acids that are mobilized as an alternative energy source when there is lack of glucose for intercellular metabolism. Starvation ketones are produced when the blood glucose is low. Ketones are also produced when insulin is lacking to initiate the transport of glucose from the blood stream through into the cell. Ketones accumulate due to low insulin levels and elevated counter-regulatory hormone levels. Thirdly, never stop insulin. This is very, very critical. Why? The insulin dose may need to be increased or decreased to maintain glucose metabolism, but it should never be stopped. You should discuss this with your doctor for dosing recommendations. The most common mistake made by healthcare providers themselves and caregivers who are unfamiliar with diabetes is to recommend the complete omission of insulin because the child is ill and not eating, thus increasing the risk for frank DKA. Even in the fasting state, some insulin is required for basal metabolic needs, which may go up during an acute illness when counter-regulatory stress hormones are elevated, so that more frequent monitoring of blood glucose and ketones is required to direct insulin dosing. If episodes of hyperglycemia, ketosis, vomiting recur with or without infection, it should be recognized that this may be due to the insulin restriction or omission. Insulin omission, what do we mean? Is particularly problematic during adolescence, whereas insulin restriction or omission also may be used as a form of paging to lose weight, representing a unique and dangerous form of disordered eating in persons with type 1 diabetes. Family dysfunction or psychiatric illness in caregiver is frequently seen in such circumstances and may contribute to the recurrence of DKA episodes. Thus should be considered since recurrence of DKA has a high association with the DKA-related complications, including coma and death. Fourthly, monitor and maintain hydration with salt and water. Hyperglycemia, fever, excessive glycosuria, and ketonuria all contribute to increased fluid losses. Liquids for hydration should contain salt and water and not just plain water, especially if there are ongoing losses associated with vomiting or diarrhea. Chicken soup, homemade lemonade with both salt and sugar, or clear broth are excellent sources of water and electrolytes, but there are so many others which you can get from your dietitian or a doctor, which may be needed to maintain hydration and to avoid water and electrolyte imbalance in conditions leading up to DKA. This is what we ought to avoid. It may be helpful to remove excessive carbonation, that we mean the bubbles in some soft drinks to minimize potential for indigestion. This can be achieved by opening the containers and allowing time for bubbles to escape along with a little shaking or stirring. Carbonated fluids may alter the distribution of food within the stomach and may contribute to bloating in some patients. Elevated levels of ketones, whether associated with hypoglycemia, that is starvation ketosis, or hyperglycemia and insulin deficiency, can contribute to nausea and may lead to decreased food and fluid intake, exhibiting dehydration, ketosis, increasing the risk for DKA. Intravenous Fluids may be required if nausea, vomiting, or diarrhea are persistent with the ongoing weight loss, especially in young children who are at great risk for dehydration without adequate internal intake. And then lastly, treat any underlying precipitating illness. This is a specific medical advice. The underlying illness should be treated as recommended for any child or adolescent without diabetes, for example, antibiotics for bacterial infections. Monitoring for clinical manifestations of some disease may be complicated in patients with diabetes in whom insulin deficiency alone can present like a gastrointestinal illness with nausea and vomiting, although one would not expect any diarrhea from insulin deficiency. Treating fever, malaise, and headache with pain medications such as paracetamol, brufen is reasonable as long as there are no allergies to these medications exist. Nausea and vomiting warrant careful scrutiny, as vomiting can be caused by either an illness itself, that is the gastroenteritis, unclean food poisoning, surgical condition, or other illness. Severe hypoglycemia, insulin deficiency resulting in hyperglycemia and ketosis, and risk for DKA. In summary, the 5 general sick day diabetes management principles are: sick day guidelines, including insulin adjustments, should be taught soon after diagnosis and reviewed at least annually with patients and family members in order to reduce the risk for DKA and for severe hypoglycemia. More frequent blood glucose and ketone, in brackets, blood or urine, monitoring. Do not stop insulin. Monitor and maintain hydration with adequate salt and water balance. Treat any underlying precipitating illness. And the final considerations for sick day management in current era of emerging technologies is: sick day management guidance should likely rely mainly on the blood glucose results obtained by fingerstick, along with blood ketone monitoring, preferably over urine ketone monitoring. Children and adolescents using automated insulin delivery devices should likely change to manual mode during sick days in order to ensure adequate supplemental insulin delivery. And lastly, I would like to share to all my listeners, thank you, merci beaucoup, maita basa, siyabonga, asante sana.